This week on the BackTable podcast, where do you see neuromodulation going in the next few years? What are some of the big topics that you see expanding?
One is new waveforms. Again, I'm working on some feasibility work now. I'm very excited about. If we have 7 different waveforms we're going to give you, and we know based on biomarkers eventually which one you're going to respond to, that'd be fantastic. We'd have very few failures. So 2 is improvement closed loop, where it learns more about your spinal cord and predicts up front. So improvement and prediction. 3 is there's some work right now on home monitoring, like you monitor your device all the time. That data is being collected very heavily. They haven't really published much of it yet. Eventually, we're going to learn what we can learn from that, and that may be very, very helpful. That remote monitoring piece can be important. There's a new area called optogenetics, where you actually can put a device in, you can shine a light in the spinal column, and we can use a viral vector to change the RNA or DNA of the DRG and maybe have some improvement in pain. It's been used for blindness so far. There's a couple of NIH-granted companies that work on that right now. I'm very excited about. I've been working with them some. So that'll be a whole new arena we haven't seen before.
Hello, everyone. Welcome back to the BackTable MSK podcast. This is your host, Jacob Fleming, returning from a brief hiatus, and I have the pleasure to be with a living legend today, the one and only Dr. Tim Deer, and we're going to talk about all things neuromodulation today. It's kind of a small topic, so I'm sure we'll breeze right through it. But Dr. Deer, I want to thank you so much for your time, and welcome to the show.
Well, Jacob, thanks for having me. It's an honor to be here with you, and I look forward to our discussion.
Thank you, and so do I. And so I'd like to say a few words before we talk. You know, the BackTable MSK show, some may or may not know, began as an offshoot of the flagship BackTable show, which is IR-based. And as we started to cover more topics related to spine and pain, we had the need for our own brand. And so after considering various brands, we went with BackTable MSK. And so we've had some misunderstandings. Oh, is it just for musculoskeletal radiology? Is it just for PM&R? And the answer is no. We want this show, and the impetus for this show is to be for all things related to musculoskeletal health and medicine. And so that includes interventional pain, it includes interventional spine, orthopedics, neurosurgery. And so I'm really excited that today we're really going to finally dive into one of the most important topics, I think, in modern musculoskeletal medicine, if you will, which is neuromodulation. And so, Dr. Deer, you've been involved with neuromodulation pretty much at every level throughout your career, and I really would like to hear your perspective on that. But before we jump in, for those of our audience who may be less familiar, can you tell us what is neuromodulation?
Yeah, so, I think neuromodulation is a area of medicine that has been always there, and I've been doing neuromodulation since my fellowship at UVA in 1994. It's when we change the nervous system by using either electricity or some form of delivered drug. And I think that has been the overall kind of big picture of neuromodulation. I think what's really been interesting is how it's really evolved with changes in technology, waveforms, devices, drugs, and now we're looking at things, like viral vectors, for example, that change the nervous system. So neuromodulation, as a general thing, is changing the neural transmission by electricity or a delivered drug, or now a delivered viral vector for some sort of genetic transformation. So it's really evolving.
Excellent. Well, thank you for that background. And as you alluded to, so you've been working on this since your fellowship year. And so can you tell us just a bit about your background, your training, and how you get to where you are now? I know it's a small topic.
No, I'll be very brief, but I'll give you a little summary. When I was in med school, I was fairly intense. I was going to go into neurosurgery, and something came out called the cardiac stent my last year of med school. And it made me think to myself, I needed to do interventional cardiology because the cardiologists were doing minimally invasive things. And so I changed paths, went to UVA to do cardiology. And while I was there, I realized I really didn't want to do internal medicine, and became an anesthesiology resident. And then pain was brand new. It was really a new field of medicine. And I really found that to be where I wanted to be. And I really found that procedures, when properly applied in a judicious fashion, were much better than drugs and other methods of treatment. So I became focused on, number one, procedural-based medicine, but 2, innovation and product development and studies. So from 1994 until now, I've spent my career trying to develop new devices, which I've been really played a role in a lot of device development, and trying to do studies that give us data and evidence to help us get patient access for these therapies. So those have been really my two goals, is innovation and data. And that's still my two goals. Here we are many years later, is to continue to innovate with people like yourself, where we come up with new ideas, and to continue to build level 1 data so we get access and reimbursement for patients.
And you've been very, very involved, very, very productive at all levels, all things including intrathecal pump medicine, the PAC guidelines, and all different kinds of level 1 trials, like you said. And so thank you for, your endeavors over your entire career. And so I imagine it must have been a lot of fun to kind of see this field of medicine develop with you. And so I'd just like to hear a little bit of perspective about that. What kind of stuff were you doing in fellowship? And then just generally, how have you seen neuromodulation evolve over time?
Well, it's always about unmet needs, right? That's what it's about. What's the unmet need? So I came out of training, there really was epidural steroids, ablation, and stimulation. And stimulation was pretty poor at that time. It was 4 contacts with a tonic waveform. And we had about 50% success rates overall, which isn't bad when you think about these are the end of the line people, but it's still not good enough. So what we saw was an evolution. So I started working with a company called ANS, and we went to 8 and 16 contact leads. That was the first changes. And then went from constant voltage to constant current devices, constant current. So that made it more pleasant for patients. And then we went to rechargeable devices in the early 2000s, so patients could get longer battery life and didn't have to have surgery so often. And then waveform development. I was involved very heavily in the development of bursts and development of high frequency. I was the chairman of the scientific study for HF10. And then we started looking at things like targets, like dorsal root ganglion stimulation. So we did the first DRG stimulation devices in the world in 2008, and that developed in 15 to FDA approval. So it's been targets, waveforms, and now what we're looking at now is, can we make things smaller? Can we make things actually more improved? And one of the recent improvements in the last decade has been closed loop. I've been very involved in closed loop studies, and we're still doing more of that now to really have the true AI is closed loop when you actually talk to the spinal cord with the device. And then lastly, I think the other thing that's really going to be a new evolving area is new waveforms. I have a feasibility study coming up with 3 new waveforms that we've developed that haven't been used in humans before, that we think may really affect other parts of the nervous system differently than the current waveforms. So eventually, I think we'll be able to dial in a waveform based on your genetics, your biomarkers, other things. And I think that development is really exciting. So I think we're still in the beginning of neuromodulation, even though it's been 30 years. I think we're in the beginning of it. And I think right now, if you're listening to this podcast, you're going to say to yourself, I'm not sure I think that's going to work. And then in 5 years, you're going to have things that you never dreamed of. So this evolution of neuromodulation is just really just starting right now.
It's an exciting time to be witnessing all this. And, I started to find out a little bit about neuromodulation only kind of in the second half of my residency. And, I'm a bit of an oddball compared to some of the other people in interventional pain because I'm from a radiology background. And so actually, I first heard from you speaking at the ASSR conference. That was back in, I think it was 2020 or 2021 during the pandemic and everything was virtual. Dan Nguyen was the chair that year, put together an excellent program, and it was life-changing for me. And so to hear about, some of the things that were going on, and now the things that you're talking about, including closed loop therapy, I wasn't even hearing about those back then. So in the last just few years, these kind of have started to come out. And I would like to hear a little bit more about closed loop. This is a fascinating thing and something I'm still wrapping my head around. So can you tell us a little bit more about what is that technology? And you mentioned kind of the AI aspect of that. How does that all play in?
Fantastic. I think it's, interesting because closed loop is a term often used by many now, and it's really not true for most. And AI is a term used by many, and it's not true for most. So I've had companies say that you have AI, but all they really have is an algorithm. They really don't have AI. So to think about this, the first closed loop was used in cochlear implants back for hearing 20 years ago. And some of the early legends in that area was Al Mann, who was a developer. He wasn't a physician or engineer, but he actually hired people to develop one implant. The other was a guy named John Parker in Australia. And John Parker did the cochlear implant company in Sydney, and he actually worked with a team of engineers to develop a closed loop spinal cord stimulation system. And I started working with him in 2011. and his team, and they actually were able to deliver current, measure an ECAP, bring it back to the device, and then change the stimulation pattern and the intensity based on the individual's ECAP. And that really is shown in multiple level 1 studies to be very successful. What's interesting, though, what's happened in the last 12 months is the filters for that have improved dramatically. And that's been machine learning, AI based. So before you'd have a signal, and you try to measure it, there'd be a lot of noise in that signal, and you have to try to have the device respond. With filtering now, it's like having someone, saying a word in a rock concert, and you have people around them and you can hear that one word. That's what a filter is. So I think what's really the evolution has gone from closed loop by getting ECAPs and responding to getting a better filter. And now we have AI automation. So it can actually, the patient can program himself really by touching their finger to a button when they can feel stimulation in different areas of their spine. And then the next steps will be more biomarker based. And we're starting to develop now. There's a study last year we looked at where we could identify on the table 90% of responders without having a 7 or 10-day trial. We knew on the table and looked 360 days later who was going to respond to that device. And I think, so that's going to be really amazing for patients where they don't have to go through 2 steps for a device eventually. And it's going to be great for payers. They don't have to pay for failed trials.
Sure.
We'll know on the table that day if it's not going to be successful, then we'll know. So I think that it's really going to become the standard for many waveforms. Now, the last thing I'll say about that is all waveforms may not need closed loop. There are some waveforms that work in the spine and the brain, and we may not need a closed loop if it's working on your anterior cingulate area, for example. It may just need to deliver the current there, and that goes up the spinal cord pathway. So we don't know exactly what all systems will need closed loop. We know that some will need it and some will be critical for it, but we don't know if all waveforms will need it.
It's fascinating because it seems like we're entering a new era of sophistication with spinal cord stimulation specifically. This applies to a lot of different things, but it seems like in the past, spinal cord stimulation has been applied almost as like a catch-all, see if this works for someone who's kind of tried almost everything, whether that's back pain, radicular pain, neuropathy. And we've certainly seen that all these disease entities don't behave the same. Different patients with ostensibly the same issues don't respond the same. And so it's really fascinating. We're getting to this level of sophistication and actually true AI to sort that out. Will be really interesting to see. And I'm sure we'll see a lot in just the next few years with that.
Well, I will say, though, that one thing I want to point out what you just said, there are certain things that have good data, right? Diabetic peripheral neuropathy has good data.
Yes.
Non-surgical back, we published a distinct study last year, which led to a level 1 IDE approval by FDA for non-surgical back. So we have these conditions with really good data, CRPS with DRG, great data. Mm-hmm. But if you pick the wrong patients who don't match the study, they'll still fail.
Right.
So I think technology won't solve patient failures if you pick the wrong patient. So I still think it's very important to be judicious in your use of these therapies because, we have some people that really, do procedures, as that probably are inappropriate. So I do think that I still preach that we have to make sure that the patient matches the study that you're referring to. If you tell a patient you have a 70, 80% chance of response rate or 86% in the EVOKE study, for example, and it's a great RCT, crossover study, but only if they match that. That's why we need more real world studies. And we're doing some real world studies in my practice now to see if we can match the level 1 study. So if you have independent level 1 studies matching the RCT that led to the approval, that's when I start to feel more comfortable that we're going to do really well.
You mentioned DRG stimulation. This is something that I found fascinating. I only did a little bit of work with this in fellowship, but really fascinating to see what it can do. And so for those who are a little less familiar, could you tell us, since you've been involved with this pretty much since the inception, tell us about DRG stimulation. How does that compare to spinal cord stimulation?
Yeah, well, we all know when you get shingles, your DRG becomes activated when it shouldn't, and you get that dermatomal pattern of pain, and it's an abnormal DRG. So in 2008, we did the first DRGs in the world. We did the first couple cases as a feasibility, and we found that people that had focal nerve pain really responded. We didn't have a sheath. We didn't have an introduction system. We didn't have a lot going on at that time. It was a very small startup company out of California. And then it led to work in Australia and the EU and England. We did a lot of work on a level 1 study in those countries that showed success with DRG stimulation. And what it does, it's a pseudo unipolar neuron junction that comes through and filters the pain signal from the periphery and neuropathic pain. And so really you're shutting that down. We know from dorsal root ganglion ectomies that it can shut down the signal. But unfortunately, as you know, that grows back and causes deafferentation pain. So to go in there and have electricity do that is quite impressive. And then the patient have focal nerve pain, whether it be CRPS or post-herniography pain or post-knee replacement pain, nothing does as well. And what's interesting is once that device malfunctions, breaks, moves, or changes, then the pain comes back immediately, as opposed to stimulation where they may have several weeks where they can't really tell what's going on. It is a harder procedure, though. It takes more skill.
Yes, so definitely.
One thing, when I teach people DRG, if you have good hands, you should learn DRG. And then once you learn it, you have to use it more often because otherwise you'll get rusty. But people with bad hands, probably not the therapy for you. It takes more skill than spinal cord stimulation by far. And it's almost like a ballet. You have to understand how to move the sheath. Now there's a new sheath that just came out from the FDA. There's going to be a new lead, new anchor next year from the FDA, most likely approved. And it'll improve, but right now it really does take a set of skills, but nothing has as good outcome in focal nerve pain as that therapy. And when successful, it can really turn around a really devastating thing like CRPS.
Yeah, absolutely. And CRPS is something I wanted to talk a little bit more about. This is just a disease that is very difficult. First of all, patients seem to go without proper diagnosis for a long time. And then it's, kind of people are often at a loss for what to do. I've heard of cases where a patient with CRPS after an ankle injury, a young patient, some of the physicians involved were offering basically an amputation. And one of our good colleagues basically advised them, don't do that because then she's going to have phantom pain in her amputated limb, and instead, consider something like DRG stimulation. And the way that something so relatively simple, at least to me, applying an electric current can actually reprogram that whole kind of runaway sympathetic activation is really fascinating.
This might be, and Jacob, thanks for bringing that up. I think this may be one of the most important parts of this discussion, and that is what CRPS type 1 and CRPS type 2 are. I had a really famous physician who was probably one of the leading KOLs in the world not know the difference recently. We were having this discussion, and he had implanted a lot of people with stimulation, and he didn't know the difference. And so, so I assumed everyone knew what CRPS type 1 and 2 were. And remember the FDA indications for both. So CRPS type 1 is, you have all those Budapest signs of the 4 changes on Budapest findings. If you Google what that is, the Budapest findings, CRPS 1 has all those things. They have allodynia, you can't touch them, they're discoloration, they have atrophy. And that's not very common anymore. That was very common in the past. Orthopedic surgeons are doing a much better job of diagnosing early physical therapy and really catching it very early. So we don't see as much of that, thankfully, anymore. CRPS type 2, though, we see a ton of. That's a nerve injury after surgery, right? So you have your hernia operation, you have neuropathic pain that really should be gone. You have your knee replaced. 20% of all knee replacements have neuropathic knee pain after knee replacement. You have foot trauma, podiatric surgery. All those things cause really focal nerve pain. It's not FDA approved in the US for upper extremity, but I do a lot of cervical DRG for upper extremity amputations of fingers, explosion injuries, failed carpal tunnel that didn't do well. So really what we're looking at here in CRPS type 2 is a focus on a nerve injury after surgery, and you don't have to have those Budapest criteria for that. And the fastest growing area right now is pelvic pain after pelvic surgery. Using the L1, S2, we're seeing some fantastic results with DRG for that group of patients. And before, a lot of pelvic pain patients were kind of hopeless. SCS doesn't work very well for them. Other things, peripheral nerve stimulation doesn't work very well. So all those things really has led to a real revolution where DRG suddenly is now more important again. And I think the pelvic pain population is really driving a lot of that, but so is the failed knee replacement patient population. And so is the podiatric patient population who has pain in the nerve after foot surgery. So all those things are causing almost a renaissance of DRG, and we're seeing it growing again overall nationwide.
And it'll be exciting to see. You mentioned a couple of hopefully new equipment coming soon. That'll be exciting to see. I definitely agree that my limited experience with DRG stimulation, it is very technically demanding, and look forward to something that can make that easier. I think about this kind of compared to early days of interventional radiology and compared to much more elegant and newer microcatheters and things like that are compared to back in the days when Charles Daughter was just making catheters in his hotel room. Not to say it's going to make it easy by any means, because it is technically demanding, but satisfying procedure, and more so than anything, getting relief for a patient who has struggled with neuropathic pain for a long time. That's very rewarding. Now, you mentioned peripheral nerve stimulation, another hot topic in the world of neuromodulation. Tell us a little bit about what's going on in the world of peripheral nerve stimulation.
Well, so peripheral nerve stimulation is something I've been doing since 20 years ago. We used to use devices made for the spine. You put them, for example, in the occipital nerve for occipital-based migraines. And now we have devices that are really made to be placed in the periphery. So the leads are tined. We have really three areas of interest. One would be the multifidus muscle. That's a form of peripheral nerve stimulation for those with multifidus atrophy on MRI findings. So that's really growing. The data there, we were involved in that study. The Reactivate study is really impressive. Then we have peripheral nerve injury from trauma and other things. And so some of the common injuries there would be trauma to the limb, so we would place a device. And right now you have to have a wearable for those peripheral nerve injuries. There's no totally implantable device that can be utilized. And then the third group is those who have joint pain. So we do a lot of shoulder PNS, so the suprascapular axillary nerve, ultrasound guided. We do the knee. I did the first FDA study in 2010, published in 15, that led to FDA approval of PNS overall. But that was really with using X-ray guidance and nerve stimulators. We didn't know how to use ultrasound at the time.
Sure.
So everyone in that study, which I only had about a 35% outcome, but it was enough to get FDA approval. Everyone in that study didn't really have it. We had no clue how close to the nerve we were. Now with the really advancements in ultrasound, we see PNS outcomes improve dramatically. And recently, there's been a couple of level 1 studies. John Hathaway and others have led those studies. Have been very impressive. And that's led to more insurance approval. Now, the future of PNS, I think, is going to be bright. I'm working right now with a startup company that isn't on the market yet, isn't approved yet, that has sensing and closed loop capabilities and eventually a totally implantable device. So I think that's where we're going with PNS as well, where we can sense the nerve. We know we have the capture. And then we can use closed loop then to make sure we have stimulation of the nerve, because one of the problems with PNS long-term is sometimes there's scar tissue. And you're not sure you're capturing the nerve any longer.
Sure.
And if you have an 8-contact lead and you have multiple chances to target it and you can sense the nerve, you'll be able to improve targeting, and then you may or may not add closed loop to that. Really, we'll be yet to see if that's needed or not. But that's really an area that I think we're going to see more and more advancement. There's a lot of investment right now in PNS, and I think it'll continue to grow.
Yeah, it's very cool to see. That's something that I feel like I've seen just really take off in the last few years and grow substantially. I haven't got into it myself personally, but have a few colleagues who are big proponents of it and have had some great outcomes. I really like what you said about the ultrasound guidance as well, because doing a lot of the fluoro-guided stuff, which, that's kind of my jam. But yeah, we're kind of assuming a nerve is in a certain place just by osseous landmarks, and what you said, the outcomes seem to reflect that actually being able to see directly or indirectly under ultrasound where the nerve is, it makes sense that would lead to better outcomes.
There's one device, I like what you said, everything you just said, I totally agree with everything you said, but there's one device out there that's only a 60-day implant, so it's not a permanent implant. And about 70% of patients have improvement. And there's some level 1 data. Chris Gilmore published, I was one of the authors, on the back and as well as on the shoulder. That 60-day experience where you put a device that's coiled so it doesn't get infected for 60 days, and you have a little dressing, you have a remote control in your pocket, you runs that device. For a lot of people wanting to get involved in PNS, a great way to start that, and I call it the gateway device to neuromodulation. If you think marijuana is the gateway to heroin, then this is a great way to neuromodulation. But I think, SPR, the Sprint system, 60 days, and then if you really have good success and it doesn't continue, then there's two great companies out there for permanent devices. So I do think you have some opportunities now. If you're not sure you're ready to go all in with permanent devices, you can do a 60-day implant. If there's a peripheral nerve you can target, and my most common nerves with that device is the shoulder after shoulder surgery, or really severe osteoarthritis in the shoulder, and the genicular nerves in the knee. Probably the two most common we go for now with that type of 60-day device.
Excellent. Now, I want to go a little bit off the cuff. So, we're talking about ultrasound and fluoro. And so I'm a musculoskeletal radiologist. And so I try to see nerves where I can, but with our standard techniques, even MRI, we typically don't have great resolution for the nerves. And so I just want to ask if you have any thoughts on kind of the current state of nerve imaging and things like MR neurography or other types of things, even ultrasound. How do you see perhaps growing sophistication with that, maybe informing our treatments or outcomes? Or do you think that it's going to remain more of a clinical assessment?
So a couple thoughts there, and then I want to bring it down to something new that I'm excited about. That we're in the first inning of all this. If it's Major League Baseball, my Yankees aren't doing very well so far this series. But so I think the things you mentioned have potential. The problem is, can they be done in real time?
Right.
Everything we're doing in real time. So I think the potential is there, but the problem is, if you can find the nerve for me, unless you can find it for me while I'm working on the nerve, it doesn't help me very much. So my real problem there is, I don't think there's evidence that we can use that in the procedural area in a timely fashion that coordinates yet. Now so I think we're maybe a decade away from that. So that's kind of a negative outlook there. There might be a chance to do some focus ultrasound though for pain, like we do in the brain for other conditions. So we may use ultrasound in treatment versus diagnoses. That'll be very, very interesting. And what really excites me, I had a company come out recently and show me, and I'm not working with that company at the moment, but they come out and show me some navigation tools for pain. Now, right now, all the navigation has been really confined to neurosurgery and things of that nature because it's so expensive, right, to have that. But there's some new work being done where you can take a device as small as an iPhone and use that for really navigation in the OR when you're doing things like kyphoplasty, or you're doing something like a BVN, which I do quite a bit of BVN work, basovertebral nerve ablation, or you're maybe doing SI fusion, which I do a lot of both lateral and posterior SI fusion. So I think the real advancement, what you asked me, is not going to be in the things you mentioned. It's going to be in a handheld navigation. And I get so much radiation some days. Tomorrow I think I have a DRG, I have an SI fusion, I have a posterior lateral arthrodesis, Minuteman, and I think I have a BVN. I'm going to get a lot of radiation tomorrow. So if I can lower that radiation dose in some fashion, and I think what we've been missing really is navigation. So I'm really excited about the next 5 years, and I do probably more MIS than I do neuromodulation anymore, although they're both very important to me. I think the reduction in radiation exposure to you and I and our colleagues is going to be more important than anything else because, we really want longevity. We don't want to have sarcoma or lymphoma when we're 50. We want to keep moving. So to me, that's going to be important. And I think we're right around the corner. We're probably within 2 or 3 years of seeing some major advancements in handheld navigation that doesn't require an O-ring or some crazy navigation ring that costs $1 million.
Yeah, that'll be great to see. And, you mentioned neurosurgery and even ortho, they've been doing this for a long time, and things like stealth. And like you said, it costs $1 bajillion. And so, most major medical centers can have navigation, but the spine surgeons have been using that for quite some time, to the point that a lot of the newer spine surgeons are really more used to doing everything under navigation, including pedicle screws, versus the old school guys who are doing it all freehand, just staring at the spine. And so to have, and then as an interventional radiologist, I'm used to doing pretty much everything under fluoro, CT, sometimes ultrasound. And yeah, sometimes, I put my radiation dose for every procedure in the report. And sometimes I'm like, oh, man, try to do everything we can to keep it down. But I think there's parallels in other regions like endovascular aortic grafts, moving towards doing a fiber optic type of things. And so I think our parallel with making navigation more, accessible, that will be a game changer, I think. So I look forward to seeing where that goes.
100%. It's going to be really interesting. And you mentioned fiber optics. I think the other area that's been pretty not great has been endoscopic surgeries. And now we're seeing improvement in scope technology. So I think the other thing we're going to see really grow in the next, decade, the next 5 years, is going to be interventional radiologists, interventional pain people doing more endoscopic work. And the scopes are finally getting to where I feel comfortable now that we know what we're looking at. So we're seeing more and more that part of our MIS certification at ASPN involves endoscopic surgery, for example. So that's the type of growth we're seeing there too. So, again, something we never thought about 5 years ago. It wasn't on our radar screen. And now it's becoming like more and more commonplace, but it's only because technology has gotten better.
Right.
And it's easier for us to use it, and I think that's it. We got to really demand more of if you do collaboration with a company, you have to demand they actually get to the point where they're really making patient efficacy and safety better. It can't be one or the other. It has to be both.
Absolutely. And you mentioned endoscopy. This is something that's just been extremely interesting to me since I kind of first heard about it. And so we're talking about applying that to do things, as relatively simple as doing the endoscopic assisted neurotomy of the medial branch, kind of, sort of a more efficacious way of doing a radiofrequency ablation. And then going to things like, doing unilateral laminotomy and bilateral decompression. And I've been really excited to see that the uptake in the spine surgery community has really advanced a lot more over the last few years. And you mentioned too, that I think that interventional pain and interventional radiology will grow in that area. I think it'll just be better for patients as, kind of the minification. I feel like endoscopic surgery is in some ways kind of the ultimate MIS when it comes to a lot of the spine treatments. And it's a perfect time to talk about what you just mentioned with ASPN and as well as the MIS certification. And so I wanted to make sure to talk to you about this. So for those who don't know, ASPN, the American Society of Pain and Neuroscience, you're one of the founders of that society, and it's just skyrocketed since it took off a few years ago. So I'd like to hear you talk a little bit about that. What was the impetus and how has it developed in the last few years, and what are your main goals?
Really appreciate that question. And I started this society in 2018 with Dawood Saed, who's a program director of pain at Kansas. And I really felt a need. I've been president or a board member of multiple societies over the years. And I really felt like there wasn't a great place. And there's many good things about all the societies. Don't get me wrong. I'm not anti the other folks. But I feel like young people had real trouble getting involved early. I felt like they had to do too many things over years and years to get themselves involved. I thought we needed a society that was more focused on mentoring and young people, helping young people do well. I felt like some of the society I was in really had 10 men over 50 in the board, no women, no younger people. I felt like there was no diversity a lot of times. So I really wanted to make diversity a real focus. And most importantly, I really felt that no one was focusing on MIS. It was always either injections or ablations or neuromodulation only. No one was focused on the whole spectrum to me. And I really saw the growth was going to be in advancing neuromodulation, but at the same time advancing MIS. And they both are so important. And to do that, we had to embrace interventional radiology. And we had to embrace neurosurgery, and we had to embrace ortho spine. And so one of our main goals in the beginning that's really played out very well. And now I'm speaking at many of the conferences of the other specialties and vice versa. Last year we had about 100 surgeons at our conference in Miami. We had about 3,000 people. About 100 of those were spine surgeons, which in the beginning, 7 years ago, we didn't have any. So we really reached out more and more. We have some spine surgeons advising our board now. We have some interventional radiologists on our board now. So I really thought it was a need there. And so we started with 80 people at a meeting in Aspen, Colorado in 2019. It was our first meeting. And we grew to about 3,500 people in Miami last year. And the reason people are attracted to that meeting is there's not a lot of lectures. It's more panels. And on those panels, you'll find multiple specialties and you'll find multiple opinions. And what's so nice is that's okay. No one tells the other person that you're wrong. We don't judge other people's opinions. We discuss what's best. And what happens is over a few years, the data proves one person wrong or the other. It's
Right.
the data that brings you around. And that's really why it's grown so much. We're going to be leaving for London tomorrow night for ASPN. And now we're starting the International Society. We started that in Dubai 2 years ago. And that's grown from about 50 people to almost 1,000 people already. And that's because I think there's a hunger worldwide to have more MIS options and more training. And we're going to do a lot of training. We're going to train on BVN and mild while we're in London. That's the first two procedures we're going to bring there. And then I think we're also going to have a lab on Minuteman. So we're going to bring some of the lower risk MIS procedures to Europe and UK. Hopefully they'll get approval through their governmental people, and we'll be working with them on that. And I think we're going to really start a worldwide revolution on improving patient care. And that's really the goal. So that's ASPN and ISPN. And anybody who listens to this, if you're an interventional radiologist, if you're an interventional orthopedic surgeon or pain physician, there's room for you. Let us know what your interest. We have a special chapter called Young Innovators, first 5 years after fellowship. And that's probably our most active group of people. And they're doing studies and they're doing all kinds of different things to really help bring forth each other's careers. And a lot of networking there.
Yeah, I've really admired the intermingling of different specialties. I think that's one thing that's a bit unique about this. I go to a lot of different society meetings too, and it tends to be, kind of mostly one specialty, and the invariably the conferences meetings where I learn the most are where there is that sort of melting pot of different backgrounds and people learn so much from each other. So I've taken things that I've learned from neurosurgeons, kind of offhand comments almost at a panel, and I was like, that's a great idea. And then you bring that back, something you would never be exposed to. And I think it's just from what I've observed, it's increased collegiality among the different specialties that are involved under this entire umbrella, which is kind of the same, I spoke about earlier. The idea for this show is similar, to kind of have an umbrella under which we can all share knowledge about these topics as we evolve. And, it doesn't take long to see, on LinkedIn, there can be a little animosity here and there, but I feel like I've really seen overall the collegiality among the Venn diagram of these specialties has really increased parallel with ASPN. So I applaud all your work on that. And so to get to one of the bigger, more exciting, more recent announcements is you spoke about this MIS certification, and which kind of gets into the whole idea of training, which obviously has to evolve as well. But tell us a little bit about what that is.
Yeah. So I was at a meeting last year with some spine surgeons, and they said, you can do that procedure, and Doug Bill can do that procedure, but everyone else shouldn't do it. And I thought, well, that's kind of ridiculous,
Yeah.
And so we had this discussion. So I decided, most fellowships in the country, even the best fellowships, they can't train you to do everything we're doing. And that means you go out, you learn from industry on a weekend, and you go back to your practice and you do it. And I'm not sure that's the best way to do it. I'm not sure it's the safest or most efficacious. So we decided we would really put our money where our mouth is and do something that really is more to advance the field and really prove things. So you apply for the certification. We have a lot of people who do it because they want to get privileges at different places, or they want to really help themselves with insurers, whatever it may be, or help themselves for future litigation, whatever it may be. But you apply for this certification. Let's say, for example, you want to do SI fusion, BVN, and MAUD. So you apply, and then you already have done the trainings. You've been to that weekend course, whatever it may be, and you get your certification. But then you get a mentor. So then let's say you have an SI fusion tomorrow, it's lateral, you're doing a lateral one screw fusion above S1. Well, then if I'm your mentor, we'll talk about that case. We'll look at your x-rays, we'll get your MRI, and we'll talk about the approaches. Doug Bill's, again, a radiology friend of mine, he's one of the mentors as well. And then you'll go do your case, and then you'll show those films. And then next week or two, we'll get back together and talk about how things went, good or bad. And we'll do that. We'll keep a case log during the year. Then you'll go visit your mentor, and you'll actually watch your mentor do some of the same procedures you're really working with and get their perspective. And then once you've done that, you also have every month you'll have a lecture on the internet with one of the mentors, and that'll be really including a lot of different things at MIS. And you'll come to Miami in July. There's a hands-on cadaver course of the things you're certified in, and you'll have Dr. Pankaj Mehta is running that out of Austin, but there'll be about 30 mentors there watching you do that. And then we'll follow that up with a written test, 100 questions. It's developed by Tolga Silver out of Rush University. He runs he's the program director there for the fellowship. So Tolga does a fantastic job, and he's having question writers there. So you'll take a written and a practical exam, you'll be certified. And then you'll be able to then become a mentor yourself. So we really want to pay it forward. So once you go through that process, and the first year we're limited to about 20 people. We want to make sure the program's really good. We're making it small. We already have about 10 international people we've accepted, and about 20 US people are going to be accepted. So we'll have about 30 total, 10 international, 20 US. So I think the program will grow, but we wanted to go pretty small the first year to make sure that we're really happy with the program development. So Dave Dickerson, Chicago's running that program. He's the chair of it. We have several folks around the country involved. And I think this is a step to make sure that we're getting mentoring after that weekend of training, because I don't care what fellowship you're in, there'll be a new procedure coming around in a month or two.
Oh, yeah.
There's always a new procedure coming around. And if you have a process, and once you've gone through that process, I think you're going to understand once you've get your certification, a new procedure comes, you're going to go seek a mentor. Even after you're certified, you're going to seek a mentor. And then you're going to mentor people. So I think it's going to really build that mentoring philosophy that ASPN's been all about since the beginning.
Well, I think this is really an innovative approach, and I think that's exactly what we need in this era where, like you said, even if you're in a just fantastic fellowship, and I am very thankful for my training, and I got a lot of exposure to certain things and not as much to other things. And so naturally what you do is kind of build this network and reach out for cases. And so I love how you're kind of formalizing this and then really putting your money where your mouth is and developing it into a full certification with the test and making sure the quality standard is all there. Nowadays, it's so hard, like you just said. There's such a dizzying array of new devices, new techniques and procedures coming out constantly. Even if you go to the most up-to-date fellowship that does everything theoretically, then within a year, there's going to be new stuff that you haven't done yet. And so we have to find ways better than just like the standard weekend course, like you were saying. And that's one of the challenges I feel right now in this area. And it's reflected also in interventional radiology. You know, we see this, and I don't do vascular work, but the expansion of vascular interventional radiology is to the point that things that were unheard of when I was a med student or even at the beginning of residency are now commonplace. And how do we keep up with that? And it has to be innovative approaches like this, I think. But on the note of training, you have any thoughts about kind of the more traditional, formal pathway of doing fellowship and kind of how you see that evolving over time? So, for example, you know, there's the pain medicine fellowships. We have the PM&R type of interventional spine and muscular medicine. I did kind of, you know, my own sort of different thing with Dr. Beal. And so, but these things are all kind of all under the same umbrella of interventional pain. So it's hard to know where it's going to go and what is the best path forward. I'm interested in your thoughts.
Well, Sandy Christensen out in Oregon just published a paper on really what's lacking in ACGME fellowship programs. You know, there's not a lot of interventional training there in a lot of those programs. And, you know, I applaud her for that. And what we find is that if you go to a non-ACGME fellowship right now, you're going to get more training probably than in an ACGME fellowship, which is, you know, not what you would expect, right? So I think that some people said we need a 2-year fellowship to solve that. If you do 2 years at a program that doesn't teach you much, it won't teach you much in 2 years and teach you much in 1 year. So I don't think that's a good answer. And nobody wants to do a 2-year fellowship. You know, all the anesthesiologists right now, they can make a lot of money out of residency. So they're not even doing fellowship at the moment. So I think that 2 years is a bad idea. I think that what we need to do is figure out a way where we, again, mentor. That's why I created this MIS certification program. But I think the fellowship programs need to change, but it's hard to change a fellowship program when it's part of a major department.
Yes,
so
absolutely.
I don't have a lot of hope that fellowship program will change. I had a fellowship director recently tell me, you really talk too much about procedures. And, you know, that's why we're having trouble getting good fellows to their program, because their program is more about biosocial feedback and all those things. I'm not saying those things aren't important, but I don't think you need to do an interventional fellowship to learn those things. So I think we need to be more focused. If you're going to spend a year somewhere, you should spend a year doing interventional procedures and learning how to do them well and learning who to do them in. If you want to learn neurology and you want to learn psychiatry and all those things, that could be another time. You maybe spend 6 extra months down the road, but there needs to be maybe a breakdown into interventional and non-interventional fellowships, because the current fellowship is just too demanding. There's no way an ACGMA director can meet all those criteria and teach you what you need to know. And that's a real problem. So I think, so that's a long answer, but what I'm telling you is I think there won't be a 2-year fellowship ever, I don't think, for most programs. And if they don't change, they're going to get left behind by ACGME non-accredited fellowships that teach interventional therapies. And I know a lot of facilities, they're okay with that. And a lot of credentialing committees don't care if you have it or not with ACGME.
Yeah, well, I really appreciate that answer. Very, very thoughtful. And it kind of shows the challenges overall. And just because the ACGME mandates something, oh, well, you know, yeah, you got to have exposure to SI fusion. I mean, yeah, you know, you can't, a lot of academic programs or institutions as a whole have a lot of inertia. And so to be able to, you know, not just introduce, but mandate exposure to certain things, I think it's just not possible.
Yeah, but they haven't mandated it. In fact, it's the opposite. They've actually taken away the number of procedures you need to do. For example, neuromodulation used to be a minimum number. That's gone away now. So I think that it's the opposite. It's gone the wrong direction in a lot of ways. And you get someone like a Scott Prisloft out in San Diego or in California, Davis doing a great job, where his fellows get a lot of training, just as an example. It's kind of unfair to a fellow who gets to go to him versus go somewhere else where they get very minimal training. Is that the same fellowship? Of course not. They have the same certificate, but it's a different fellowship. So I do think there's some fellowship directors out there who hold themselves to a higher standard. And I applaud those people.
Mm-hmm. Absolutely. So yeah, thanks for humoring me on kind of that detour there to talk about training. I think it's a very important topic. To bring it back to neuromodulation, I did just have a few extra questions, and you talked about some of the evolving topics there, but I'm interested to hear, just in general, where do you see neuromodulation going in the next few years? What are some of the big topics that you see expanding?
Great question. So I'll just give you a few and I'll make it very succinct. One is new waveforms. Again, I'm working on some feasibility work now. I'm very excited about. If we have 7 different waveforms we're going to give you, and we know based on biomarkers eventually which one you're going to respond to, that'd be fantastic. We'd have very few failures. So new waveforms. 2 is improvement closed loop, where it learns more about your spinal cord and predicts up front. So improvement and prediction. Who's going to do well? 3 is there's some work right now on home monitoring, like you monitor your device all the time. That data is being collected very heavily. They haven't really published much of it yet. Eventually, we're going to learn what we can learn from that, and that may be very, very helpful. That remote monitoring piece can be important. There's a new area called optogenetics, where you actually can put a device in, you can shine a light in the spinal column, and we can use a viral vector to change the RNA or DNA of the DRG and maybe have some improvement in pain. It's been used for blindness so far. There's a couple of NIH-granted companies that work on that right now. I'm very excited about. I've been working with them some. So that'll be a whole new arena we haven't seen before. I think that could be quite promising. I think we're going to see more and more work on totally implantable PNS systems that have sensing technology. And that'll make PNS, again, much more easy to use for patients, improve wearability. So those are some of the things I think we're going to see. I think for the head and neck, I'm not real optimistic about devices that go implantable. We're going to see a lot of external devices that work just as well. But for the spine, the peripheral nerves, I think we're still looking mostly peripherally. One exception to that, there are some devices now where you have external stimulation of the peripheral nerve in sessions, and we've seen some improvement, particularly in those who have subacute chronic nerve pain. So we may see some expansion to non-implantable devices in the periphery, but that's really pretty limited to one company right now.
Well, a lot of very, very exciting stuff to look forward to, a lot to be optimistic about. So thank you for your thoughts on that. And to give kind of the flip side to that, I'd like to hear, what do you think are the current biggest challenges to the therapy? And what do you see as perhaps some of the looming challenges?
Well, I think one is patient selection being poor for a lot of doctors. They put it in the wrong patients. And, I think that you can look at your own numbers down the road and see what your 5-year explant number is. And a lot of people don't know what their explant number is because people leave them and go somewhere else across town and get explanted. So I think patient selection is still the biggest challenge. I think insurance being unethical when they say something is experimental when it's not. That's a challenge, right? When you know something has a CPT code is approved and the insurance company tells the patient it's experimental, that's a real challenge. So we have to really face that every day. And we really overcome that by data. I think that's really where we are. And then thirdly, I think there's a real movement in the press sometimes, in Australia, for example, where they really push for things that are non-interventional, which they think cost less. And so they may be very negative towards spinal cord stimulation, for example, in the Cochrane study in Australia, because they're pushing for, medication management and things of that nature. So I think sometimes there's some hidden agendas out there, but I think we overcome all that with level 1 data. We overcome all that with registries. I think there's a real need for registries. That's the last thing I'll mention about Aspen. We just did an RFP for registries. We're down to the final 2 companies. We're going to do a membership registry where we track data out of the EHR for practices where you know how your patients do, and you can compare it to national averages, and we can use that to really help us with payers. So I think a registry will overcome a lot of these challenges you're mentioning, because we can show if we really are getting good results, we can show it. And guess what? If things fail in a certain group of patients, we can show that too and quit doing that group of patients. So I think we can use it for both, really knowledge of who to implant, but also knowledge of who not to implant, versus the insurance company just out of the blue saying something doesn't work for someone without any good reason for saying that.
Well, thank you so much. You've given me a lot to think about. I'm going to be having a hard time falling asleep tonight just thinking about all the different things that are coming around the pipeline in neuromodulation. And overall, I'm just very encouraged to see a bright future for neuromodulation. Very, very interested to see how things evolve over the next few years. So Dr. Deere, I really want to thank you for your time coming on to share your wisdom with our audience and me. And definitely want to have you back on the show sometime, anytime you'd like, to keep us apprised of the latest updates. And so before we finish up, this is your time to plug anything, mention anything you'd like.
No, I really don't have anything much to plug. July, if you go to our website, www.aspenpain.com, July in Miami, Fountain Blue, certainly invite your colleagues to join us. And then they want to get involved in Aspen. We do a lot of things. We just really working on advocacy right now, getting a lot of really reimbursement decision reverse. Hema Kalea is doing a fantastic job as our vice president of reimbursement and regulatory, doing a fantastic job. So if you have an interest, come join us in Miami and then get involved with our society, and certainly welcome radiologists and physiatrists. So we have quite a bit of both already, and we'd love to have you join us. So thank you for the time, Jacob. I appreciate the time to talk with you, and I think this is a fantastic podcast. I'm honored to be on it. Thank you.
Thank you so much, Dr. Garrett. To our audience, thanks for tuning in, and we'll catch you next time. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.